last one. At the onset, I would like to thank Dr. Arup. There was a crisis in the morning. They don't allow you to connect the laptop, and then you have to convert everything to Windows. This happened to me about 15 years back at the ACRS, where there were 2 Apple computers and 85 Windows computers. And now if you go to the ACRS, there are 95 Apple computers and 2 Windows computers. And in this conference, we are not allowed Apple computers, so it's interesting. Anyway, I hope all my slides work. Recent concepts in post-refractive situation is what I'm going to say. So this happens to all of us when this situation comes. And as time goes by, I'm doing LASIK since 1999. So a lot of patients are coming back due to having a cataract, and then the confusion as to what to really do. So there is a rise, no doubt, in post-refractive number. And IOL calculations, it is known that keratometry results in 27% of the error. IOL misalignment is 14%, IOL tilt is 11%, and angle kappa is 7.5%. So keratometry does play a very important role, and if it's a post-refractive case, it will play even a bigger role. So what to look for? Yes, we have to look for corneal shape, very important, corneal power analysis. So now we all talk about total corneal power, topography, tomography, angle kappa. Dominance used to play a role. We used to always look for non-dominant eye and dominant eye depending on the ad of the IOL that we want to place for the patient. But now dominance is not because of the new trifocal IOLs. Dominance does not play that important a role because it's a non-dominant eye, you'll still use a trifocal, and you have a dominant eye, you'll still use a trifocal. Of course, you have to look at corneal aberrations. So high-order aberrations have to be there, but I'll tell you some experience of mine. Tear film analysis, macular status, and the rest of it all remains the same. So this is one example where I'm showing no financial interest, where I'm showing anterior analysis. He spoke about IOL Master 700. Here it is important that we get all the calculations. Here you can see that all the calculations are together. So you have the right eye, the left eye for comparison. You have total corneal power. So the anterior corneal power and the posterior corneal power are different in post-refractive cases, right? So that's what we want to understand. Angle kappa is more relevant in hyperopic than myopic LASIK. And of course, biometry, corneal map, and angle kappa. So you have a full-on display of both eyes at the same time. You can do, that is a Barrett calculation here, and there is a Holiday calculation here. You can see that also on that side. And now if you go to another case where you have total corneal wavefront, so you have a corneal wavelength analysis, and here you can actually look at the high-order aberrations, so you can compare biometry, you can compare corneal aberrations, and you get an idea of white to white. So you have full analysis in one shot of each eye, and this is important as far as post-refractive cases are concerned. So entire toric planning can be done together, and this gives you anterior corneal astigmatism, posterior corneal astigmatism. You can decide where to place your incision, and incision can be set manually. Again, if you are not getting an axial lens sometimes, if it is a dense cataract, sometimes you may not get a reading, you can do an immersion and enter it manually, and that itself will also help you. So as far as premium IOLs are concerned in post-refractive cases, one is keratometry, and two is looking at the corneal wavefront or a high-order aberration, which is there, which is important in a central 3 millimeter zone. So you can see there is an anterior curvature and there is a posterior curvature. And this changes in post-refractive cases or RK operated will not change so much as post-LASIK myopic or post-LASIK hyperopic. So that's important. And so you have a total anterior surface, posterior surface, pachymetry, and refractive index, and this will give you the total corneal power, which is very, very important for analysis. Again, as age increases, you have to look at posterior corneal astigmatism. So by age increasing, the steep meridian, okay, of the anterior corneal surface changes in the direction from vertical to horizontal. Remember this. So the anterior corneal surface, as we grow older, from vertical becomes horizontal. The posterior surface really doesn't change much. So this is what is being found over the number of years. So what is important as far as refractive planning is concerned is, of course, to look at the ablation pattern. Sometimes you can have a decentered ablation. Very, very important to do topography. If you have a decentered ablation, you can still, there is a tricks of managing these cases. I can tell you later on what if time permits. But if you have a decentered ablation, be careful in selecting your IOL. Of course, look at the point spread function. Don't forget the point spread function is of the cornea, not of the complete eye. If you look at this point spread function of the total wavefront of the eye, it's wrong because cataract is going to contribute to that. Only look at the corneal point spread function. So Optical biometry is a rule. Use any formula as mentioned. I like to use a Barrett, gives good results, and right now we are doing all of this quite well. Need to talk to the patient about expectations. Remember that spectacle independence is important for them because they've had LASIK for so many years. They want to be spectacle independent. And of course, what kind of IOL to use is the next step. When it comes to planning of incision, make sure you know where your hinge is. Sometimes you tend to go close to the hinge, and do not do LRIs on a femto in post-LASIK or post-refractive cases, because that's not going to work the same way. It's going to behave very differently. So it's better to do a toric IOL in case you want to do like that. Do not touch the epithelium. Post-PRK, of course, determine if there is any haze or not, and post-RK, you may need wound suturing. Here, just an example of post-myopic patient, 55-year-old, done LASIK many, many years back. So you can see it's a long eye. Anterior chamber is 2.63. Length thickness is good. Keratometry and white to white is good. So here we did an ACD calculation. Is very, very important. And I'll tell you why, that you have to look at ACD. As per a study, deep ACDs given in a toric IOL corrects a lower amount of corneal cylinder when it comes to myopia, and when it is a hyperopia, is exactly opposite. So look at ACD when it comes to correction of IOL. Now this IOL calculation for the same myopic patient, you can see that we went ahead. The Barrett said 22, so Anterion also said 22, and I did multiple calculations. So ASCRS calculation 22, ASCRS Anterion 22, and IOL Master 22. So you can do multiple calculations and yet get a conclusion. And this patient, I did go ahead with a 22 diopter synergy, and the patient was 6/6 part and N6. So patients with post-myopic, you should not have a problem. Now the question coming to hyperopic LASIK. This is very controversial. I have done trifocals in hyperopic LASIK. Theoretically, it's a contraindication. So don't worry about it. It's the mind which actually adapts. So do not just throw them out. I had a discussion, and now I have 12 eyes. Bilateral hyperopic LASIK with a trifocal IOL, and patients are extremely happy. So I'll just show one example. High hyperopia, shallow anterior chamber, PI done, patient has a cataract. So you can see it's a short eye, a very shallow anterior chamber, 1.92, lens thickness which is very high, and keratometry which was 43, and a white to white which is small. We did multiple calculations, and this patient underwent again a trifocal IOL, and you can see a 31.5. Again, a patient is 6/6 part and N6. So the myth that a hyperopic LASIK cannot have a trifocal, I think it's between our mind and our eyes and our science. But most of the patients do extremely well, and they're quite happy with it. Coming to post-RK, so you can see 8-cut RK. Here, of course, this is how the topography will look. Calculations are easier because the anterior flattening and the posterior flattening is equal. You can see it's a long eye. ACD is good. Lens thickness is 4.51. It's a flat cornea because the patient had RK, and a white to white is large. And here, of course, the patient went ahead. So you do a multiple calculation. You can see that 24.5 max is 25.57. Again, we look at the EKR. The Anterion Barrett said 25, ASCRS said this, and I use the 25.5. Of course, you're targeting a little bit of myopia because there is a shift in these patients. So to cover up that shift, you go ahead and do this. Okay, I'll just take a second more. This is just a case where the patient, if this plays, I don't think it's going to play. So that saved, it's going to play. Very good. So this is a femtorexis, again, post-refractive, and a trifocal lens going in. The beauty of a femtorexis, controversial. Those who don't have it will say not necessary. But I've been doing femto now since 9 years. And if I had my own eye, I would definitely do a femto because IOLs center automatically. The rexis is made in the center of the bag. When you put the IOL in the bag, the IOL just centers. You don't need to nudge it to center it. So aberrations, very, very important. This is our friend Amar, who's invented the pinhole pupilloplasty. If you have high order aberrations, you can do a pupilloplasty, small pinhole pupilloplasty, and it removes and improves the quality of vision. Of course, imaging is important as far as this is concerned. So we look at the angle, which is very, very important, whether it's myopic or hyperopic, and look at high order aberrations, refractive surgery, and all the other parameters are needed. Thank you all for your attention.
Thanks a lot, Kumar. Maybe we can take up a discussion if Kumar is still at the end of the session. Atul, we will follow the schedule right now. So Atul, your slides, he'll be talking to us on contemporary tools to optimize toric outcomes. I think you have to set timer as 8 minutes.
Hello. Good morning. At the outset, I thank Dr. Arup sir for giving me this opportunity. My topic is contemporary tools, strategies to optimize the toric outcomes. Before to start with, I just want to see why we need all this optimization. You have to understand the new mindset of the patients. The cataracts are going for the decades, but now the patients after cataracts want to see what they see before they develop their cataract. So you have to be very much perfect in your outcome. Though the advances in biometry, intraocular lens, and the surgical techniques, they have improved our refractive outcomes. But the post-operative astigmatism is a major cause of poor post-operative uncorrected visual acuity. And so we have toric IOLs to combat for that. Calculating the best intraocular lens power for patients undergoing cataract surgery remains a key part of achieving a patient satisfaction. If you see the factors that contribute to the inaccuracy in calculation of an toric IOL, it's either an inaccurate measurement of anterior astigmatism, variability in SIA, an incorrect estimation of the posterior corneal astigmatism. There are so many toric calculators, so maybe not using a proper toric calculator, and there are some special situations. So if you go with the first thing, that is the inaccurate measurements of corneal anterior astigmatism, there are two issues in keratometry, tear film related, and there is a variability in axis and power. You know that the same instrument gives different reading at different times, or even if the amount of astigmatism that is calculated with different instruments is not exactly the same. So to tackle this issue, we know that there are so many instruments where you can measure this: a manual keratometer, auto keratometer, optical, corneal topographers with placidodisc. Then we have an OpScan initially few years back. Then we have a slim plug camera systems like Pentacam, Wavelight, Galilei, and Cirrus. And to add to the list, we can have a keratometry from the vapor and aberrometry and a ray tracing also. The tear film related, we must understand due to the variation in ocular surface, keratometry has the potential to be one of the least accurate part of the measurement process, because it's a dynamic. In addition, as we get older, the ocular surface becomes less stable. So that many of these placidodisc measurements, they are very sensitive to these tear film irregularities. So what are the tools or the strategies that I use to optimize this issue of calculating the anterior corneal power properly? Take a reading on a virgin cornea. It should be quick reading. There should not be any rubbing on the cornea. The centration has to be proper. And see to it that the axis consistency is more rather than a power. You may have a little bit variation in the power, but the axis has to be consistent. That means you are taking a good reading. Regarding the another, what you have to have some pre-operative screening. Like if you are calculating the things, there are some red flags you should know. If the axial lengths of the two eyes differ more than 0.1 millimeter, if the keratometry differs with more than 0.5 diopter difference, and if the IOL power difference in the both eyes more than 1 diopter, think that something is wrong. You have to take again the repeat measurements. Maybe you can use a corneal topographer, maybe use another instrument to calculate the things, so that this is giving the red flags. And regarding the uniocular criteria, you should look when you do a keratometry with an optical biometer that the standard deviation, it is there. It has to be not more than 30 micron. It is almost equals to 0.2 diopter. And also you have to see that the signal to noise ratio for your axial length measurement should be less, so that you can validate that the measurement that has been given is to the mark. If you find that is not up to the mark, then you can take a measurement on a different instruments. So this way, regarding the tear film related measurements, do always warm compresses or lid scrubs, artificial tears to improve the ocular surface before biometry. And I think it is generally, rather than taking reading from 3 or 4 instruments, let us concentrate on one instrument with the proper validation of the criteria as said by the company, and the consistent results from the multiple measurements from the same instruments. The second factor that is a variability in SIA. We all know that importance of SIA directly amounts the amount and the axis of post-incisional astigmatism. Even with a small incision and in the fixed meridians, this SIA is highly variable. So significant positive correlation is found between the preoperative corneal astigmatism magnitude and SIA. Means if you are dealing with a cornea with high cylinder, then the SIA may not be that which we are putting in a routine regular astigmatism cases. So we should customize SIA. drhills.com site is there, and there are every surgeon should know his SIA, and it has to be calculated in the proper way. All the guidelines has been given properly at the site of drhill.com site. The third point, that is the incorrect estimation of the effect of PCA. See, the posterior corneal astigmatism accounts for 0.25 to almost 0.75 diopter, though it seems to be small, but it matters a lot in the premium surgery. And it not only alters the cylindrical power, but also alters the axis of placement of toric IOLs to achieve the emetropia. So this, if you ignore PCA, you will end up in undercorrection of astigmatism in against the rule, and overcorrection in the cases with the rule astigmatism. There are so many methods to calculate the actual PCA measurements, but you can have toric calculators which incorporate ECA either by direct inclusion or by estimation with a fixed ratio. And there are some methods like they can overcome these inaccurate prediction errors of PCA with the help of different formulas. Now you can see this is a case, the astigmatism seems to be only 0.47, but when I calculate it comes to be around 1 to 1.25. So this is because of the PCA. There are so many toric calculators we know. Canes, Barrett toric calculator with predicted and with actual measurements, Holidays, Hopper QST, EVO. These all toric calculators, it has been found that the Barrett toric calculator gives it gives a very good result. The calculator with predicted PCA rather than with the actual measurements putting in there, actual measurements of posterior corneal astigmatism and putting in the formula. Though it allows now the readings to be taken from the AIOC2024 or a Schlempuck device like IOL Master 700 and Pentacam, but studies had proved that the one which gives better result is the one with predicted PCA, like that. There are studies recently that the Barrett toric formula with and without PCA measurements using the IOL Master 700 and the Kane toric formula result in accurate and comparable outcomes. ESCRS sites have a one-stop solution. You put a data there of your keratometry readings, and you get at one set the 4 calculators readings: Barrett, EVO, Hopper QST, and Kane. So you can have, you just don't have to put readings in different formulas. You had one-stop solution for that. Now some special situations like the IOL spherical power also influences the cylindrical power at the corneal plane. So it means if you are dealing with an eye with a high axial length, or if you are dealing with an eye with a short axial length, these also matters because the cylindrical powers varies according to the spherical power of the cornea in a very high cases.
We'll have to move on. No?
Yeah, last slide. Regarding the corneal refractive surgery, already sir had given this. So can we reach 100% accuracy? The unfortunate reality is now that we cannot get because we have a limitations. The accuracy of our measurements has limits. We are measuring a live changing system, and there is a limit to our ability to predict the IOL where the IOL is going to sit. So accuracy of 0.5 diopter is also supposed to be a gold standard. So that is at the end we can say that though we with an IOL calculation formula we have an accurate power, but there are so many factors in giving the perfect toric outcomes. Thank you.